Greetings. We just do a audio and visual check. Please make sure that you can hear me okay and can see me. Thank you.
Good evening. Greetings, sir. Thank you so much for joining the session. Greetings, all.
God.
So, we're going to start with this session in few minutes. Thank you.
Leave that place. Welcome to the Empower Group, a global organization with a mission to transform the way people learn, work, and save lives. We execute our mission by working through 3 centers and organizations: the Center for Leadership and Development, the Center for Digital Learning and Animation, and the Empower School of Health.
To date, we have delivered more than 1 million hours of training in over 100 countries to thousands of students in all areas of public health, such as disease management, immunization, antimicrobial resistance, supply chain management, regulatory affairs, access to medicines, and so on.
We implement these programs by partnering with organizations which include ministries of health, UN agencies, civil society organizations, and the private sector. We are transforming the approach of capacity building by moving away from expensive classroom-based training and introducing digital and blended learning. We design comprehensive and innovative learning strategies, which include web-based trainings that are built on Empower's open source learning management solution. We design content that is customized to the learner's requirements, including micro-learning and content in local languages. And for more complex topics, we design content using virtual and augmented reality to provide a more immersive learning experience. Another unique feature built into our learning strategy is our adaptive assessment tool, which allows learners and managers to review their growth over time and also compare their outcome with peers in their own organization or even with peers from other countries. Finally, we like to make learning fun, and so we bring elements of animation and games into our content and learning designs.
And with this, we have the ambition of being able to reach much larger numbers of people, reaching all the actors of the primary care system, all the community workers at the last mile. This is how we can help transform systems of health and improve their performance. We have a great team, among them former chiefs of states, former ministers of health, former high-level diplomats, specialists in public health, in supply chain, in training, and of course, in information technology.
For more information, please visit our offices in Geneva, New York, New Delhi, Dakar, and Kathmandu. For more information, you can also contact us at www.empoweringmillions.org. Welcome to the Empower Group, a global organization with a mission to transform the way people learn, work, and save lives. We execute our mission by working through 3 centers and organizations: the Center for Leadership and Development, the Center for Digital Learning and Animation, and the Empower School of Health.
To date, we have delivered more than 1 million hours of training in over 100 countries to thousands of students in all areas of public health, such as disease management, immunization, antimicrobial resistance, supply chain management, regulatory affairs, access to medicines, and so on.
We implement these programs by partnering with organizations which include ministries of health, UN agencies, civil society organizations, and the private sector. We are transforming the approach of capacity building by moving away from expensive classroom-based training and introducing digital and blended learning. We design comprehensive and innovative learning strategies, which include web-based trainings that are built on Empower's open source learning management solution. We design content that is customized to the learner's requirements, including micro-learning and content in local languages. And for more complex topics, we design content using virtual and augmented reality to provide a more immersive learning experience. Another unique feature built into our learning strategy is our adaptive assessment tool, which allows learners and managers to review their growth over time and also compare their outcome with peers in their own organization or even with peers from other countries. Finally, we like to make learning fun, and so we bring elements of animation and games into our content and learning designs.
And with this, we have the ambition of being able to reach much larger numbers of people, reaching all the actors of the primary care system, all the community workers at the last mile. This is how we can help transform systems of health and improve their performance. We have a great team, among them former chiefs of states, former ministers of health, former high-level diplomats, specialists in public health, in supply chain, in training, and of course, in information technology.
For more information, please visit our offices in Geneva, New York, New Delhi, Dakar, and Kathmandu. For more information, you can also contact us at www.empoweringmillions.org. Welcome to the Empower Group, a global organization with a mission to transform the way people learn, work, and save lives. We execute our mission by working through 3 centers and organizations: the Center for Leadership and Development, the Center for Digital Learning and Animation, and the Empower School of Health.
To date, we have delivered more than 1 million hours of training in over 100 countries to thousands of students in all areas of public health, such as disease management, immunization, antimicrobial resistance, supply chain management, regulatory affairs, access to medicines, and so on.
We implement these programs by partnering with organizations which include ministries of health, UN agencies, civil society organizations, and the private sector. We are transforming the approach of capacity building by moving away from expensive classroom-based training and introducing digital and blended learning. We design comprehensive and innovative learning strategies, which include web-based trainings that are built on Empower's open source learning management solution. We design content that is customized to the learner's requirements, including micro-learning and content in local languages. And for more complex topics, we design content using virtual and augmented reality to provide a more immersive learning experience. Another unique feature built into our learning strategy is our adaptive assessment tool, which allows learners and managers to review their growth over time and also compare their outcome with peers in their own organization or even with peers from other countries. Finally, we like to make learning fun, and so we bring elements of animation and games into our content and learning designs.
And with this, we have the ambition of being able to reach much larger numbers of people, reaching all the actors of the primary care system, all the community workers at the last mile. This is how we can help transform systems of health and improve their performance. We have a great team. Among them, former chiefs of states, former ministers of health, former high-level diplomats, specialists in public health, in supply chain, in training, and of course, in information technology.
For more information, please visit our offices in Geneva, New York, New Delhi, Dakar, and Kathmandu. For more information, you can also contact us at www.empoweringmillions.org.
Greetings. Hopefully we'll be ready to start in just a few seconds. Greetings to all and welcome to this webinar on forecasting and quantification of health commodities. I'm sorry we're a little late. We had some technical issues around the video refusing to stop, but we're off and running now and we'll try and make up for lost time. Next slide, please. As usual, please turn your mic off and video until we come to the Q&A session. If you have any questions, please type them into the chat box. We'll get to you, or raise your hand on the icon at the bottom of the screen. You can ask questions at any time in the chat box. Please only unmute when you are invited to speak. Of course, the slide deck will be provided to you and the webinar will be on the usual Empower channels. Next slide, please. The main point of these webinars is to give you a chance to ask questions. I'm afraid I'll talk quite a lot to summarize the modules, but hopefully there'll be enough time for you to raise all the questions that may have arisen as you've undertaken the modules. Next slide, please. Agenda for today, we're running a little bit late, which is we'll look at the questions that were raised from module 2 and just spend a few moments on those. And then we'll go into the main point of module 3, quantification. What are we trying to achieve? And then a QA session, followed by a longer presentation on forecasting and quantification of health commodities, and then a second Q&A session up to the 90-minute level. Next slide, please. From module 2, we had quite a few questions about what electronic essential medicine lists are available. So next slide, please. There is a list here. The link is on the screen and you will get the slide deck with the links of the electronic essential medicine lists which are available. Many more countries than are listed on the WHO website have electronic versions of their essential medicine list, but you have to search for them individually. This only covers the Eastern Mediterranean region. Next slide, please. Of course, WHO has a fully electronic, searchable essential medicine list. That's available. The link is on the screen. You can search by therapeutic category, by medicine, by population. It is accessible. It's open to all. The link is available on the screen, and that can be used as the basis for your own electronic essential medicine list in country if you wish. So it is available. It's still as a beta version. So it's not fully operational, but all the search functions on it do work. Next slide, please. If you want to compare your essential medicine list to other countries, the link is on the screen. You can compare how many medicines is on your list. So about 400 on the WHO essential model list. You can compare how many your country has, and you can see from the world graphic there how different countries compare, how some countries have a large number of medicines and others not so many on their essential medicine list. Next slide, please. For an example of a fully electronic essential medicine list, unfortunately, it's only available in Indonesian language. That's the Catalog Elektronik from the government of Indonesia. That's an e-catalog and combined essential medicine list. So it's got different essential medicine lists for different levels of the country: national level, district level, university hospital level, or by sector, by TB and other items. And next slide, please. And in this catalog, it lists every medicine with an indicative price and the basic features of the medicine. Link is on the screen to go forward, but again, it's only available in Indonesian language. Next slide, please. From module 2, we also got requests, what about essential lists for medical devices, for diagnostics and medical equipment? Next slide, please. The answer is yes, there are many. There's the concept of the WHO priority medical devices. That was done in 2007, and that's listed. But there are 18 different lists for different kinds of medical device. Next slide, please. And here you can see some of the lists. There's one list for essential diagnostics. There's one list just for diabetic and cardiovascular equipment. There's a new list just issued for COVID equipment. There are many lists, but exactly the same like essential medicines. You get the essential list of medical equipment, of diagnostics and medical devices, but in each category area rather than one huge list all put together. Next slide, please. So the essential devices categories, as we've said, there's the core medical equipment from X-ray machines through to baby incubators, the essential in vitro diagnostics for laboratory use, and the latest new COVID equipment. Many publications following the same format as the essential medicine list. Next slide, please. The medical devices list out the devices with detailed specifications for each piece of medical equipment. For an X-ray machine, it runs to many pages. For a tongue depressor, it's just a few lines. So all of them are covered and all of them are described in the different publications. Next slide, please. And diagnostics, also the essential list of in vitro diagnostics, a full list together with the list of pre-qualified suppliers. Which suppliers are pre-qualified by WHO for all of the diagnostics. The lists and the links are available on the screen. Next slide, please. Core medical equipment, that is the essential medical equipment for each level of the system. There are over 10,000 different types of medical device. The core list does not list all of them. It is the essential equipment. The example given is an anesthesia unit, and it contains the basic specifications for that equipment on a fact sheet for each of the items identified as core, the essential medical equipment. Next slide, please. Just published is the essential COVID equipment, and for each device you will find a detailed technical specification as well. What kind of ventilators do you need for COVID patients? It's listed on the screen with the technical specifications given. Again, the link to that publication is given on the screen. Next slide, please. Okay, on to forecasting of medical commodities. I believe all of you have completed module 3, so you've been through the hardest module of the course. That's the good news, perhaps. But let's say a few words about that and how it comes about. Next slide, please. Let's start first by just reminding ourselves of the different definitions between forecasting and quantification. Unfortunately, the terms are really used interchangeably now, but technically, forecasting is long-term projection of need, multi-year, whereas quantification is for the next order. For the next procurement, for the next tender, for the next purchase order is quantification. For perhaps a 5-year period is forecasting. That's the basic difference. But again, the terms are often used interchangeably now, and people say forecasting when they mean quantification and say quantification when they mean forecasting. Slightly different approach to how we do the longer term and the next order calculations. Next slide, please. So what are we trying to do in quantification? And we're trying to achieve the 6 rights. That's the right medicine in the right quantity for the right patient at the right time in the right condition at the right price. All of that is involved in quantification. Next slide, please. How do we do it? We follow the PSM cycle. And the key point here is that quantification is not a standalone activity. It's linked with the whole of the PSM cycle. And in order to undertake quantification, we need institutional PSM capacity. It means we've got management capacity, we've got procurement policies. We can't undertake quantification if we don't know what the procurement policies are. That we've got quality assurance, that's product quality assurance. We're aware of international and national laws, that we've got full coordination. There's often many suppliers, many people. In some countries, vitamin A program has got 5 different organizations supplying vitamin A capsules. We have to try and coordinate amongst them for quantification. And we've got reliable management information systems. Next slide, please. Well, why is quantification so hard? Why have I said that this module 3 quantification is the most difficult module of the course? And the answer is really in 3 parts. The first part is around lead time. Because often the materials that I'm ordering today will not get used for 24 months' time. So I have to try and achieve the 6 rights, not today, but in 24 months' time. What's the right medicine going to be in 2 years' time? What's the right quantity going to be in 2 years' time? It's relatively easy to know what the right medicine is now, but what will it be in 2 years? Okay. Sorry, go forward, please, on the slide. Yeah, and again, one more. That's fine. Okay. I also need reliable data. And that's a problem because frankly, in most public health systems, I don't have reliable data. I don't know absolutely what's in stock. I don't know how much I've used because the clinics don't report. I don't get 100% reporting, and the reports I do get are often not that accurate. So I'm making all my calculations based on inaccurate figures. And finally, I don't have that many staff who have been adequately trained in quantification techniques. And especially for the specialist products like antiretroviral medicines and artesunate combination therapy for malaria. They have special quantification requirements. Malaria is often seasonal. It occurs during the wet, the rainy season. How do I adjust? How do I move my quantification for that? I need specialist training, and often that's not happened. So I have these three major constraints around quantification, and that's why it's so hard. Next slide, please. We have to recognize that healthcare, procurement and supply chain management is fundamentally different from other products and other techniques. Because quantification for fast-moving consumer products like bags of sugar and butter are relatively easy. But I'm trying to keep an inventory typically of 6 months buffer stock. That's a lot more than the fast-moving consumer items. I've got an obsolescence of around 3%. Means every year 3% of my medicines and devices are not going to be used anymore. They're phased out, they're replaced. And I've got a manufacturing lead time of 180 days. That's 25 times more than fast-moving consumer goods. So when we try to compare with other sectors, healthcare is completely different, and we cannot use the techniques that are used in the electronics industry or the automotive industry. They don't work for healthcare. We have to have a fundamentally different approach, because I've got a lot of inventory, serious levels of obsolescence, and very long lead times. Even before I add in the tenders and the procurement, the manufacturing lead time is long. And that gives us really serious challenges in quantification. Next slide, please. So if I try to predict the future, what is the right medicine going to be in 24 months' time when I'm using it? Antiretrovirals, there's been 15 major changes in the medicines in the last 10 years. More than one per year. They're changing the medicines all the time for antiretrovirals. If I order what I'm using today, by the time I come to use it in 2 years' time, it will be wrong. I have to try and predict what the medicine's going to be in 2 years' time. Next slide, please. Also, the ratio of the medicines I'm using can change in just a few months. For fixed dose combinations, in just 3 months, they went from 0 up to 40% of the medicines being used to treat antiretrovirals. And other medicines went from 50% down to 10% in just 3 months. But I'm trying to plan 24 months in the future. How can I cope with massive changes in treatment ratios like this? Next slide, please. For second-line ARV treatment, it's even greater changes. They go up and down all the time as the number of second-line treatment patients changes. New medicines are introduced, and that also changes the ratio of the mix as well. Next slide, please. I have to get it to the clinic at the right time. That is before they run out, before they're out of stock. In order to do that, I need to use a risk management approach and manage all the risks in the supply chain. But very few pharmacists have been trained in risk management. As part of this course, we'll introduce the concept of risk management and undertake how to undertake supply chain risks. But in the past, that's not occurred. So there's been a lot of out of stock. And then when I'm out of stock, I get corrupt figures and I can't use that data for future forecasts. Next slide, please. I have to try and get the right price, but the price is changing all the time. COVID has really messed up prices. They've spiked up, down, and some are still up. If I look at the orange chart here, if I'd have delayed 3 months in my order, I would have saved a lot of money. So instead of ordering 1 year's supply, perhaps I should have made my quantification just for 3 months at one time and kept placing new orders. I'd have saved a lot of money. On the green line, it wouldn't have made much difference. So I have to try and predict what the future prices are going to be as well, because that will affect how much to order, and that will affect my quantification. Next slide, please. Cost predictions are notoriously unreliable, and they're really not good. So predicting the future on prices of medicines and health commodities is exceptionally difficult and rarely works well. Next slide, please. But I've given you lots of problems. The overall message is it can work. We can make quantification work, and we can make it work well if we use evidence-based, proven policies, methods, and mechanisms. If we follow formal systems of quantification, which are internationally recognized, then we can succeed. Why do we need these formal systems? Well, one reason is if you don't use one of the formal systems, the donors won't pay. Global Fund rejects about 40% of PSM plans because the quantification is nonsense. They've not used a formal system. They've just calculated some numbers, and that means it's out. They won't pay, they won't fund. And increasingly, ministries of finance and in-country self-funding is doing exactly the same. They want to see that you followed a formal quantification methodology, not just made a few calculations. Next slide, please. It's not new. Quantification techniques were published way back in '82 when we wrote the first edition of Managing Drug Supply, the Yellow Book. And WHO did it in '88, and the Logistics Handbook did it again in '98, all following the formal system. Next slide, please. It's really not new. Many of you will have heard the name Pythagoras from school geometry. Well, he was the first logistician. He wrote the first formula for consumption quantification 2,500 years ago. So now we should be getting it right. The Roman army 2,000 years ago were undertaking consumption quantification, and Alexander the Great's army did morbidity quantification 2,000 years ago. So by now, we ought to be able to get it right. Next slide, please. Okay, now it's time for our first Q&A session. If you'd like to type questions into the chat box or raise a hand and we'll try and come to you. Okay, quantification for child, I hope nutrition, not malnutrition. Okay. I don't know of any. I'll have to look for it. It's a long time since I did Plumpy Nut. There is a UNICEF formula for Plumpy Nut, but I don't know about more general child nutritional products. I'll have to check on that. Okay, if you have a question, please raise your hand and we'll try and get to you. Okay, if you want to ask a question, just unmute and go ahead and ask, okay? I don't see any hands raised, so please, if you have a question, just unmute yourself and ask the question. Okay, got one question. We're doing quantification. We don't have LMIS data. If you can't do consumption quantification, you have to do morbidity or proxy consumption quantification. Both are described in module 3, how to undertake both of those. Proxy consumption, if you really don't have any data and it's not a morbidity-based activity. But generally try to use, okay, which method is more efficient? There is no one method that fits every case. In the module, we explain and compare the different methods and the different circumstances where they are most advantage, where they can be put together well, and how to compare them across different data. Generally speaking, quantification by the consumption method has the potential to be the most accurate, but only the potential. If you don't have good data, it's never going to be accurate. And regrettably, most of our systems in low-income countries don't have good data. Lab commodities, yes, we'll come to that. I'll give you the book on quantification of lab commodities. It's undertaken exactly the same way, both by consumption and morbidity and proxy consumption quantification. There's a separate manual just for diagnostics and lab commodities. We'll give you the link in a few slides' time. Risk management approach of quantification. Basically, you identify the risks and you try to mitigate the risks. So one of the risks might be that you have poor quality data. What can you do about poor quality data? Well, in the module, we gave you a formula for adjusting for out of stock conditions. Yeah. In other areas, we may have to increase the buffer stock because I don't know my data is good quality, I'm taking a risk. That's one of the key areas we do it. Increasing buffer stock, but not necessarily held in country. I can increase the buffer through increased pipeline management as well. How can we validate and verify that we have sufficient data? We measure the quality of the data. How many of your clinics report? How accurate are the reports? Basically, you do supervision, you go to the clinic and compare the reported quantities with the actual quantities on hand. Compare the used quantities with the issue records with the prescriptions in the clinic. When do we use demographic data for quantification? That's under the morbidity method. What's the maximum months for buffer stock? Well, you can't have more buffer stock than the shelf life of the product. Other than that, it depends on the calculation and your risk management approach. Okay, demographic data is also used for contraceptives and family planning products. We also use demographic data to do a check, and I'll talk about that a little bit later in a few slides' time. If you want to raise your hand and ask a question, please do so. That's on the reaction buttons. You go to the reaction button and raise hand if you wish to ask a question. How to conduct data quality evaluation during desk review of the inventory. Okay. Basically, you go to the clinic and you measure. You do a supervision visit, you compare reported quantities of actual quantities, and that gives you a measure of the data quality. Okay, Francis Judicel, you have a question. Please unmute and ask the question. Francis Judicel. Okay, good. Please ask the question.
Okay, yep. Thank you, Professor. So I just like to, you come back. It's not a question, but you were quickly when you are explaining the difference between forecasting and quantification. I just like to come back about this difference.
Okay, forecasting is multi-year. Typically, I do a 5-year forecast. I will predict how much I need each year for the next 5 years. That's a forecast. So I don't normally do that on quantities, I do it on budgets.
Okay.
The quantification is to place the next order. To place the next order, I need detailed quantities of each product.
Okay.
Yep.
Thank you very much.
Okay,
I have a question.
yeah, please go ahead, Momin Yaro.
All right, thank you so much, Professor. I do work for an organization based in USA, and we support Ministry of Health in Africa. And sometimes we don't get to travel to the countries. We have to evaluate the inventory report before shipping new drugs. So my concern today is how I can validate the data quality I get from the inventory report from my position here in the United States. I'm not able to be in the country. What are the ways or the tools, the avenues I can use in order to appreciate the data that I'm receiving from Ministry of Health?
Right, we compare the data with morbidity. So if they report using this much medicine, how many cases does that respond to? And you compare that with the clinic registers or with the health information system reports. How many cases of childhood pneumonia did they treat? How much amoxicillin did they use? Does it seem reasonable? Is there a reasonable match between the two? Is it within 15% match? If it's outside 15%, something's probably wrong. So we compare morbidity with consumption and see if that fits. That's how we can measure data quality if we can't physically go and do inventory counts or clinic records. Does that help? Okay, I have a question on forecasting. 3-year planning is a forecast, yes. Anything beyond the next order is a forecast. COVID-19 treatment to avoid wastage, coming to it very soon. How to undertake COVID quantifications. How can we prioritize products? Coming to it very soon, in a few slides' time. What can we do when we only have the morbidity method and the disease is changing rapidly? That's a risk management. We have to try and arrange buffer stocks and flexible procurement is the simple answer to that. Okay, I'll take one more, which is Manila Vaidya. You have your hand raised. Would you like to ask a question? Please unmute. Manila Vaidya. Yeah, go ahead, please.
Hello, Professor Adi. So like a very a small concern, you mentioned that the forecasting is like kind of estimation or for the 5 years or, the multi-year forecasting, and the quantification you mentioned for the next order. So isn't that the quantification process complete once you have the forecasting and the supply planning? Is that whole the quantification is? This might.
No, the quantification is the actual quantities of the commodities you need.
Yes, that we place the order for the next procurement, yes.
Right,
So
the forecast
when we
only needs to be the budget.
Yes, it's only the estimation of the commodity for the certain period of the time, maybe 1 year or 5 year, isn't it? So when we have like a forecasting for a 1 year period, then we had what stock we have, what commodity in the pipeline, then that will be come up with a supply plan. Yeah, we develop the supply plan for placing the order for the the order for the next procurement. And so in one of the delivered book for the forecasting and quantification, I have read there are the three different steps. Like one is the preparation, second one is the forecasting, and third one is the supply planning. That whole three processes complete the quantification process.
That's correct. Yes, absolutely. You need all three processes together.
Yes.
That's the ideal situation. Unfortunately, in many of our countries, we don't have the ideal, but yes,
Okay.
absolutely correct.
Okay. Thank you, Professor Andy.
Okay. Okay, I've got one more, which is about quantification of antibiotics when there's irrational use. Again, we have to manage that by combining morbidity with consumption data. We combine two methods of quantification, morbidity and consumption quantification. And in the module, we gave you a series of charts of what to do when the two quantification techniques don't match. That's in the module training. Follow that chart and that will assist you with that situation. Again, we've asked maximum months of stock for buffer stock. You can't have more than the expiry date. However, beyond that, there is no set level. It depends what your calculation is. And you can manage buffer stocks in many ways, particularly through pipeline management as well. Okay, I'm going to stop there and we'll come back to the second QA session in around 25 minutes. Right, okay. So we'll come back to the presentations and then that will hopefully answer some of the questions and we'll have another Q&A session. Okay, next slide, please. Okay, can we go to the next slide? Okay, it looks like we have a few technical problems today. Okay, let's see what we can do here. Okay, we appear to have lost. Okay. Okay, then I'll have to try and, okay, right. It's like we're just rebooting for a second, so I'll take a few more. Just while we're waiting for the screen to get back up, I'll take a few more questions. Okay. Stock out of adult doses, the facility gets to use pediatric doses for adult clients. If it's really necessary, then yes, that's what you have to do. It's not ideal. Children are not small adults. Pediatric formulations are usually different. Okay, I think I'll. Okay, I'll try and share from my screen. Okay. Okay. I hope you can all see the screen. If someone can just confirm you can see the screen.
Yeah, we can see, Prof.
Okay, all right then. So why are we doing all this? It's all done by computers now. I don't need to know all this about quantification. I just put the numbers in the computer and that does everything, doesn't it? Well, unfortunately not. We still need what we call liveware. I'm sure you're familiar with hardware and software. We also need liveware. Liveware means people. We need people who can think, because the computer will not document the quantification process for you. It will not assess the reliability of the data you have. It will not explain the assumptions that you have to use, and it will not cross-check the end results. We need people who can undertake comparisons with science and arts and make the whole process work. So quantification is not just a calculation. It is a management function. Too often we have to work with very poor quality data, and that follows the GIGO system. And GIGO is garbage in, garbage out. If you put garbage in to your computer software, you will certainly get garbage out. Formal methods of quantification, some are given on the screen there. All the links are there. I think you're probably familiar with most of them. These are all well-established and documented quantification techniques. They're all very similar. It doesn't matter which one you follow. It does matter that you follow a formal system, which is internationally accepted, of quantification. There are lots of publications for specialist quantities. There's a publication just for HIV test kits. There are separate publications for diagnostics, for malaria commodities, for TB commodities. They're all there. They build on the basic technique, but they bring specific requirements for those commodities. Well, how do I know that this quantification training that I've put you through tortured you on this module 3 to do all these calculations, really complex and difficult? How do I know it works? Well, one of the questions you had was around COVID quantification. WHO, in conjunction with partners, has produced the WHO Essential Supplies Forecasting Tool, the ESFT, for COVID commodities. It's Excel-based and it uses morbidity methods of quantification. And it includes medicines in it, as well as PPE and diagnostics, and some equipment and oxygen therapy as well. Link is on the screen. If you've not already used it, I recommend that you have a look at it. So what is it? It's an Excel-based sheet that uses morbidity-based quantification using algorithms which are preloaded. So how much PPE do you need for gowns? And here you can see a healthcare worker needs 1 per day, a cleaner needs 1 per day, an informal caregiver, ambulance personnel, the biomedical engineer needs 1 per day. How many examination gloves do you need? Well, a healthcare worker needs 24. An informal caregiver needs 4 pairs, the ambulance needs 4 pairs, the engineer needs 2 pairs, so it goes on. All of that is preloaded in on a morbidity-based quantification. That means you enter how many cases you've got, that's morbidity. If you don't know how many COVID cases you've got, the front end will help you calculate. Every country population is loaded and their rate of COVID is loaded into this. And that will calculate for you on the front end how many you've got if you don't know. If you have the information for your country, you enter that data and this will do the calculation. And it uses exactly the same formula that you did in module 3 for morbidity quantification. Exactly the same formula. So you've already used this kind of Excel quantification sheet during module 3. Already been through it, except this is set up for doing COVID patients. It's got the drug list, it's got PPE, it's got diagnostics, all built in to these calculations. Well, that's great. But what is the evidence you've got that this training helps us? Well, from the survey of countries in Southeast Asia, they surveyed how well they were able to use this WHO essential supplies forecasting tool for their COVID commodities. And all the staff who had completed the Empower postgraduate diploma course could use the ESFT tool immediately and relatively easily. They all got good results with it. Countries with little quantification training, they had a lot of trouble using it. And the countries who said, no, it's just too complicated, we're not going to do it. Unfortunately, the donors said there's no money for you. So this tool was considered to be good and reasonably accurate, but a bit needed some skill to use. You've got that skills because you've completed module 3. You've done the quantification, you've done morbidity quantification. And that's the advantage of the skills. You can take a tool like this and run with it straight away. Another pandemic comes, there'll be another tool for that pandemic. Morbidity-based, you'll be able to use it. That's our evidence that this skills training really works. My key message around quantification is people focus too much on the calculations. Quantification is a management process. It requires a team effort and stakeholder engagement and managing the whole process. And that's where we fall down. We concentrate too much on doing the calculations and not enough on managing the process. Let's recognize some of the health and monetary impacts. The Global Fund estimates that 40% of its grants goes in products. So 40% of the total health budget goes in health products, mainly pharmaceuticals, diagnostics, and medical devices. We take an example for antiretroviral medicines. And a low-income country with a GDP of 800, a population of 50 million, and they've got 1.7 million people living with HIV. If the real need is 15.3 million bottles of fixed dose combination ARV per annum, and I make a 5% error in my quantification. So if I make an error and it's 5% less than the need, 63,750 patients will not receive ARVs. Around 10%, 6,375 will become very ill, and about 2,550 will die. Just a 5% error in calculating how much is needed. If I order 5% more than is needed, around 38,250 bottles will date expire before I can use them. And that will be a monetary loss of about $382,500. More importantly, the donors might well get annoyed with me and stop funding for the future because I'm wasting medicines. So just a 5% error can bring that kind of impact. 2,500 people die and $382,000 wasted. That's why we have to make quantification the best we can do. It really is important that we try and get it right. And we get it right by following a management process. Starting off with the need for good governance. Well, what's good governance got to do with these calculations? Good governance brings aspects of transparency and openness. And that means even if I get it wrong, all the donors, all the people funding can see how I did it, how I went about it, and understand that we use the best possible mechanisms. So even if I get it wrong, they're likely to accept that I did the best that was possible at that time. And part of good governance is having an independent observer on your quantification team. How many countries have an independent observer? Even now, 15 years after WHO brought forward good governance in quantification, we still don't have that in most countries. I've also got to lever the management effort. Quantification needs time and resources, but often I don't plan. I don't tell people how much money, how much staff I'm going to need and how long it's going to take. It's always last minute. I've got to make the order now. Do the quantification tomorrow. It doesn't work like that. I have to plan the quantification process and allow time and allocate resources to get it right. If I don't, some people will die or I will waste a lot of money. That's how important quantification is, and that's why we need the resources to do it. So my key message here is change the focus from the arithmetic to management. Understand it's a management process. Make the quantification complete. Understand the resources that I need to undertake quantification. And it's a problem because I often don't have good data. So I'm going to have to make assumptions and estimates. What's the lead time? I ought to know what the lead time is, but I'm often not measuring it properly. So I have to estimate it because I don't have good records of how long it took between the order and between the delivery. So I have to use a Delphic method, which is a committee of experts. And I need time to put this committee together and ask the great and the good for their opinion. It's not just the chief pharmacist saying the lead time is 3 months, off you go. We have to make the best estimate we can. And that means using the Delphi method. I've got to agree the level of safety stock that I need. I have to adjust for losses. How much expires? Often I don't know what my rate of expiry is because I'm not measuring it. So I have to try and estimate what the expiry rate is. I've got to cross-check the results of the quantification, morbidity against consumption, against demographic data. I've got to check the medicine prices because they will have increased because of the COVID pandemic. And I've got to try and adjust and reconcile the final quantities. It's a lot of work. And I have to have time and resources to do it. Well, it's not possible to do this for every item. I've got 400 items on the essential medicine list. How can I possibly do this for every item? Because every item will have a different lead time. Well, it is possible. The private sector does it every day, but they generally have good data. So in the short to medium term, I need to focus my quantification efforts on the priority items. And I do that in 2 ways, the clinical need and the economic impact. So let's start with the clinical need. Nobody dies from indigestion. It's not that important if the quantification is not so reliable. If I don't have antacids, nobody's going to die. If I don't have antiretroviral medicines, people might die. So the first point of my focus is clinical need. The next one is around cost. Paracetamol costs about 1 cent per tablet. It doesn't matter if I order a bit too much and some expires. It's only going to be a few dollars. That's not really that important. I don't have to spend a lot of time undertaking the paracetamol quantification. So I am going to use evidence-based procedures to focus my quantification efforts based on clinical need and economic reality. Many of you will already know about the Venn system of clinical importance: vital, essential, non-essential. We classify the medicines according to this, and many country essential medicine lists already have the Venn system incorporated. We'll talk a lot more about Venn in later modules, but basically it means the life-saving medicines, they're vital. The antibiotics, the cardiac medicines, intravenous solutions. I'm going to spend a lot of time on those. The antacids are not that important. They're non-essential. I'm not going to spend a lot of time on those. So if I split my essential medicine list down into these three categories, vital, essential, non-essential. So vital is life-saving, insulin. I haven't got insulin, people will die. That's vital, that's life-saving. Okay? Into non-essential items, many dermatological preparations are not life-threatening. I don't need to worry too much about them. So here is an essential medicine list, and you can see the EVEN classifications. This example is from Namibia, but many essential medicine lists already have this classification built in. The point around this is there aren't many vital items. You don't get a lot. In my essential medicine list, I can look at that, it's probably less than 20% vital items. So I can focus on those because those really matter. If I don't get the quantification right, people could die. I then look at the economic importance, and we use a system, a management principle called the Pareto principle, which is that 20% has got the largest economic impact. So 20% of my medicines are 80% of the cost. And that's pretty much true across all countries. If I take my essential medicine list, what I bought last year, what was my order from last year, and I put it together and I add up, I will find that around 20% is 80% of the cost. 80% of the items only cost 20% of my budget. So that 20% that cost 80% of my budget, they are economically important. It's important that I get them right. I look at the A categories, it comes out to 20%. Pretty much the same across all countries, not much variation. I then put together Venn and ABC. I add together all my vital items and all my A items of economically responsible, and I don't get many. In a typical essential medicine list, I'll get less than 50 that are really important, that really matter. They're vital and they cost a lot of money. So I am going to focus my attention on those V and A items, the vital and the A 20% that costs 80% of the budget. And I'm going to really do a good job of quantification on those and not worry too much about the other items. Of course, I'm going to calculate how much is needed, but I'm not going to spend a lot of time with the Delphic committees calculating individual lead times, individual expiry and wastage rates. I'm just going to use block lead times and block expiry rates. Lots of questions around data. No one expects your data to be 100% accurate, but we do expect your data to get better with time. And unfortunately, in many countries, that's not the case. If we look at the survey of Global Fund, what they found is 11 out of 15 countries, their data for quantification was inaccurate. It just wasn't good enough to do a decent quantification. Well, Global Fund's been going for 15 years now. You've had 15 years to improve the quality of your data. And if we don't start getting better, Global Fund is going to stop the grants. That's the reality. We have to get data better. Assessing data quality, you can see bottom right of the screen and you'll see the link to data quality completeness, how to take that through. Because I don't have good data, I often have to make assumptions. What is the wastage rate in my program? I don't know, because it's not reported. What's the expiry rate in my program? I don't know because it's not reported. So I have to try and make the assumption using my Delphic committee. And there are processes for doing that and guidance, and we give you some in the training material for the module, and there's more on the links on the screen. Point around that is I can't keep using that excuse. I'm going to have to get better data in the future. Computers in quantification, yes, of course we're going to use computers. There are several excellent software programs that will help, but I don't know of any one software package that does it all. All of them are good at doing one part of it. So that means we have to try and combine them and work together, and that's why we need the management approach to quantification. Cross-checking. One example from a country here. This was for IUDs, intrauterine devices, sometimes called the copper T, for family planning. So issues data was considered really good. The warehouse was really accurate until we compared it with the morbidity data. And we found out enough IUDs have been issued for every man, woman, and child in the province, which would have been really painful for the males. Cross-check the data. Does it make sense? Look at the consumption data with the morbidity data, with the supply chain data. How does it cross-check? Undertake consumption and morbidity quantification if you can. Compare the two. There are charts available in Module 3 to show you which system to adopt when you compare the two. In the Global Fund survey, only 11% of country quantifications were cross-checking. They were making the calculations and that's it, finished. Not surprisingly, Global Fund is starting to get annoyed with us about our quantification techniques. Quantification reports, you need to make the full report. And in particular, you need to record all the figures so that you can compare them next year. How well did we do? That was our forecast. What did we actually use? How well did it compare? And we can adjust our assumptions and our quantification for the next year if I know what I did last year. And that means it needs to be all in the report. Okay, I'm going to skip over those. Okay, so the basic message is that quantification is a management process. Too much emphasis has been placed on the calculations. Manage the process. Quantification works. Witness the COVID ESFT tool. We do need to improve data, and good quantification requires real evidence. Okay, it's time for Q&A. Let's see what questions I've got in the box first. Pareto method. When can we use ABC? ABC is a method used throughout essential medicines. It's how we focus. Pareto method is that 20% of the medicines account for 80% of the budget. It's a technique we use to bring economic focus. We can use it in the warehouse. We use it in supply chain management, in prioritization. We use it in quality assurance. We'll explain more about it in coming modules, far more detail. But basic method is 20% of the medicines account for 80% of the cost. So that's where I'm going to focus. Not just economic focus, I use two techniques, clinical importance and economic focus. Okay, let's see if I can look back up. Okay, we'll rely on private organizations. You go forward exactly the same techniques, same quantification with the private organizations. In a number of countries, they are implemented through NGOs. So that's exactly the same. Same technique, there's no problem with it. Then is successful when it's available. We've seen N products become V. Yes, it can happen. And different users put products in different categories. You might consider aspirin to be an N item, but if it's used for cardiac control, that would be a V item. Fortunately, we use a different formulation. So 75 milligram aspirin might be considered as V vital, whereas 350 or 500 milligram aspirin might be considered as an N item. Yes, it can move categories. What we're saying is it's a focus. Focus the quantification effort on the V and A items until you have good data, but work on getting better data so that in future we don't need to focus. We can use good data on all of our items. How do we measure the rate of expiry? You can do it based on cost. That's a crude method, but it's a start. You report how many items expired. You do a crude percentage cost base. That's possible. We talked about expiry rates in module 1, and I gave you the baseline figure of about 3.5%, and I suggested that you should be under 2.5% expiry if possible. But you can take that, and if you've got a report per item, measure the rate of expiry per item, or at least per class of item. Measure the rate of expiry on antiretrovirals so that you know what it is for all the antiretrovirals. Measure it for artesunate combination therapy so you know what it is for all the antimalarials. It's one way to do it. We start to bring a more focused approach. How can a country best manage FEFO to push first short-dated medicines? You put the items at the front of the shelf is the simple method. Some countries use color-coded stickers on the boxes, but basically you display the box with the expiry date clearly written on it, and you put the short-dated items at the front of the shelves. Also, try to give the short-dated items to places that use a lot, like hospitals. Clinics might have a very low turnover. If I issue them short-dated items, they might not be able to use it before the expiry date. But hospitals generally got a larger turnover, they might be able to use it. Okay. Okay, if anyone has a question, please raise your hand and I'll try and come to you. Preposition of humanitarian supplies. The best forecasting method, we use humanitarian forecasting. There's a separate manual for humanitarian forecasting techniques, and we have a separate course for humanitarian forecasting. But basically, you preposition according to the Venn system, the vital items and the ones most likely using a risk management approach. So we use a risk management scoring matrix to identify the high risk items and we pre-position them. Does it work? Yes, absolutely. Thailand pre-positioned PPE, ready for an outbreak. So when COVID hit, they already had everything in place ready. They could start immediately because they had all the PPE pre-positioned in place. The full techniques are given in the humanitarian manual guides. I'll send you the links on the next one. If you have a question, please raise your hand and I'll try and come to you. Okay, you can type in the box. Or please raise your hand and unmute. If you want to ask a question, you can just unmute if that's easier and go ahead and ask the question. Don't be shy, we're all among friends here. Okay, I have a question here on pack size variations. For example, sizes of exam gloves. We quantify exam gloves individually by different size. Don't treat them as one product. If you are using multi-size exam gloves, and most countries just use small, medium, and large for examination gloves. Surgeons' gloves are different. We do that by size, but treat each item as a separate product. So small exam gloves is one product, medium exam gloves is the second product, large exam gloves is a third product. Quantify them separately. Is there a documented practice in managing low shelf life commodities in relation to push and pull systems? Yes, we try and send low shelf life products to high usage. One of the problems is people interpret FEFO too simply. They think first expired, just send it to the first place that makes a request. No, if it's a short expiry date, it's no good sending 10 bottles to a clinic that only uses 1 bottle a month. Yeah? Look at where it's going and their usage level. So send short expiry dates to high volume users, which is normally hospitals, not just to clinics. Okay, Manila Vaidya, I see you've got your hand up if you would like to ask a question. Please go
Professor,
ahead.
yes. So how frequently do we need to review the forecast accuracy, the calculating the forecast accuracy?
Right, I recommend redoing the forecast every 3 months.
Okay, thank you.
Okay, morbidity quantification. How do we handle patients who switched to alternative medicines because we were out of stock? Yes, it's a problem. If we don't have data, we have to estimate, and that means using the Delphic committees to estimate how many patients switched and how many are going to switch back again. We use the Delphic committee. In most countries, there will be a drug and therapeutic committee. We can try and call upon them. And for the particular disease, we ask the experts involved with that disease. That's the TB program, HIV, malaria programs, or diabetes, hypertension programs, whichever is involved in patient switching. See if I can find any more. Okay. Got any more questions? Please raise your hand. We have a few minutes left. Okay, Manila again. Okay, go ahead, please.
So sometimes for essential drug, like the items like the adrenaline and all, sometimes we need I've been using sometimes the allocation method, like the allocating this much of the quantity like adrenaline, some like the life-saving medicine. Is that the right way that what I am doing? Just to confirm,
Sometimes it's the only way.
Yeah, because
we have to use
for the
a
life-saving
system.
Exactly, rationing system, like allocating certain quantity.
What I do recommend is that you use a Delphic committee to do it.
Yeah, of course, like with the committee, like with their permission.
We've all had to do it when we first introduced antiretroviral medicines. We never had enough. We had to ration supply. Difficult decisions can affect lives.
Yeah, the consensus with the team. Yes.
Yep.
Yep. Sorry, so one more question to ask.
Go ahead.
So like, is there any best methods for the family planning commodity, the forecasting of the family planning commodity? Like what best method, like there are varieties of the method, like the consumption method or, the morbidity method, or like for the family planning commodities, especially, is there the best method to go?
There's no
with?
best method. Some commodities respond better than others. Generally,
Okay.
condoms better than on-consumption method.
Okay, so we can
Oral
still.
contraceptives are better done on morbidity method.
Okay, so like we can but triangulate the data by using the different method, yes?
Yes.
Okay.
I mean, you
Okay.
can't issue more condoms than there are men in the country. Yeah?
Yes, of course.
So it does need both methods as a cross check on what's
Yes.
going on.
Okay. Thank you, Professor Andy.
Okay, I think we're out of time. I'll just ask if Empower Admin wants to say a few words. I think you're back with us now. We're okay. Yeah. Okay, then it falls to me.
Thank you
Go
so
ahead.
much. I'm sorry, sir. Thank you so much for your session, sir. It's really grateful that we have you here to clear all the doubts of these candidates. So it's really great. And thank you all for joining this session. Kindly note that the recording of the session will be updated on our YouTube channel, and I have already shared the link with you all in the chat box. Please get it from there. I request you to please subscribe the channel and to get all the updates related to the recording and PPT slides there. Also, we are planning to host the graduation ceremony on Thursday, which is 16th September. So we have already got the information from our candidates, but if you haven't got the invite and you have already completed the course, please reach out to me on my email, and I am giving you and I'm dropping here my WhatsApp number as well, so you can connect me on my WhatsApp number directly. Okay. So thank you so much. See you again in our next expert session. The details will be shared with you soon. Thank you. Thank you, sir.
Good night to all, and thank you for joining us this day.